Thank you for having me this morning. So I am CEO of RIMIDI. I have our RIMIDI on FHIR logo that I have to say was a really big hit at HIMSS, and I should have brought stickers because that was our #1 giveaway, was giving away our RIMIDI on FHIR stickers at the HIMSS conference. But a little bit about who we are as a company. So we're a 5-year-old software startup company based in Atlanta, Georgia, at the ATDC at Georgia Tech accelerator for high-tech companies. I'm a physician scientist by background, did the MSTP program at Emory, and had spent some time in the mobile technology space, and became interested in inefficiencies in our healthcare system and how to address those. Happened to meet an engineer who had spent 40 years in academia working on closed-loop control systems for diabetes management, and our company was born out of that. So RIMIDI's primary focus to date has been diabetes optimization and really leveraging closed-loop control algorithms and technology that was, like the previous speaker, really well studied and proven in academia, and how to bring that to the practice of medicine and how to commercialize that technology. Let's see. There we go. So our first product at RIMIDI is called Diabetes Plus Me. It's a platform used by health systems to address the diabetes problem. As far as scope of the problem, so 30 million people in the US with diabetes today, but the statistic that really interests me is that only 18% of those meet their treatment goals. So diabetes, we have $1 billion a year invested in NIH funds into diabetes management, and we do a really terrible job at executing on that in the real world. And so we at RIMIDI are looking at not just the scope of the problem, but what's really the issue of why diabetes continues to drive avoidable morbidity and mortality, right? So kidney failure, blindness, amputation of limbs. Why is that still happening in 2017 when we invest $1 billion a year of research money into this disease? And how do we avoid that? And so when you look at historically programs that have been effective at diabetes management, they've been very labor intensive. And so to address this problem at scale, as we move into value-based care, and we're looking at how do we cost effectively provide better care and lower healthcare costs, technology is clearly a part of that. We need to start letting technology do the part it does well, data analysis, predictive modeling, and let the doctors and nurses and humans do the part they do well. And so that's our goal at RIMIDI, is how to support everybody involved in diabetes with the tools they need. And it's a team sport, right? We need patients, we need nurses, we need doctors, all on the same plan, operating with the same data set on the same platform. So we've built and deployed a software platform that interacts with patients. We do remote patient monitoring and data capture there. So a patient can integrate their Bluetooth or cellular-enabled glucose meter, their fitness tracker, their scale that they have at home, their blood pressure cuff. All of that data comes to us mostly through Bluetooth, but also through API integrations with cellular-enabled devices or through third-party hubs like HealthKit. Our job is to help that data make sense to that patient and help them know how they're doing against their care plan, but also to provide that data to the healthcare team in a meaningful way. So in the world of diabetes management, there's a great example. When continuous glucose monitors came out and we had this enormous stream of data coming to clinicians, they couldn't deal with it. They couldn't look at it. I mean, until they got a billing code to be able to review continuous glucose monitor data, many of them didn't, because it didn't fit into their workflow. They weren't paid more to spend more time. And so I think it's a really good lesson to us in how we look at remote monitoring in general. Of clinicians don't want data, they want insights, they want tools to leverage that data to really make a difference. So we have been doing this as a standalone application for a couple of years now. We're deployed in commercial contracts, but we've really been waiting for FHIR to come along to solve our problem of integrating into the clinical workflow at scale. Because what we want to do is empower that doctor or nurse to achieve their goal, at the moment they want to in their workflow. And so I'm going to show you what this integration looks like with Cerner PowerChart. We have been really excited to show this both at their conference as well as at the HIMSS Interoperability Showcase. and really, I think, shows the power of what Smart on FHIR can achieve from a clinical workflow point of view. So when the clinician is in PowerChart and you see in the red box there the Smart Diabetes Plus Me link, when they click that link, they are authenticated to our system. So that clinician is authenticated to RIMIDI, and we do the back and forth handshake on that, as well as into that patient's record. So that right there in their workflow, they're able to access that patient, Mr. Jake Boxer's information, where they would normally be doing, their diabetes review with that patient. So instead of going to 5 different places within the EMR to look at labs, to look at medications, to look at vital signs, they can have all of that data pulled together for them in one place. In our clinical interface, so we do consider ourselves to be a clinical decision support company in a couple of different ways. One is this analytics and risk scoring that we're doing to give the clinician a global view of what's happening with this patient. So that 72 there is a 0 to 100 scale of how is this patient doing against practice guidelines. And so we're taking outcomes data like, A1C, BMI, LDL. We're taking medication data and best practices. Is this patient on the right medications that are indicated for diabetes, as well as screenings, and we're pulling all of that data into our system. So right now, we are integrated and pulling that data via FHIR calls for the vital signs, for laboratory, for medications, for allergies, directly into RIMIDI. So on launch, we make those calls, and we pull that data in. This just sort of gives you a feel for the place that, today, that clinician is having to go to find the data that we just looked at there in our header. And obviously, it's not telling that comprehensive, clear picture to the clinician when they're seeing these data points sort of in disparate windows throughout the experience. And then we're marrying that data with the patient self-monitor data, because it's really a 2-part story, right? What's happening at this point in time when I see a patient in my clinic or when I'm reviewing their chart and I'm looking at clinical data, and then what's happening with that patient the other 361 days a year when they're in charge of their care. And as we move, again, to this population health focus and value-based care, clinicians now have that responsibility 365 days a year for what's happening with their population. And that's a really heavy lift to make that transition. So here you see pulling in blood glucose data that's color-coded against that patient's goals, makes it visually very easy for me to tell where the patient's in range, out of range, green is good, blue is high. You see little symbols for their exercise status, their stress, a weight they took at home, et cetera. That's really metadata, contextual data. So again, the patient can do one-time OAuth, authorization to say, yes, Fitbit, share your data with RIMIDI. Yes, this cellular-enabled scale or glucometer, share that data with RIMIDI, and then that data passively comes to us. This gives the ability in the workflow for when clinicians are doing sort of offline management, right? So I'm a nurse practitioner, I'm a diabetes educator looking at this patient chart. The number of minutes and hours that add up that they are spending trying to follow up as they transition to this proactive management with a patient, did they start that new medication? What happened? Have they had trouble with it? They can come in here and automatically see that. They can click the message patient button and send a text message directly to a patient of like, great job this week, keep it up. Or I haven't seen a blood glucose reading in a week, what's going on? I need that data to help you. So we're really looking always for ways that we can drive efficiency and automate the sort of high-touch relationship between a provider and a patient. I don't know if I mentioned, but we are pulling in medication data as well. And the medications are a big deal in our model because that's what's driving our clinical decision support algorithms as well. So this part of the technology is what came out of closed-loop control artificial pancreas work, where we create a statistical model of the most likely blood glucose values for a patient and allow the provider, so here you see where we're pulling in medications, and we allow them to superimpose changes. So I can say, I think I need to put this patient on long-acting insulin to address their glucose. And it will actually it will show me in a predictive model what's going to happen to their blood glucose. So instead of handing a patient a prescription, waiting 6 months for them to come back, I can do it on screen. This generates a care plan for the patient. So let me just quickly, because I got the 5-minute warning, say that this whole care plan is then going to go back to that patient electronically. We do also provide global population-level outcomes for the provider. But just to show you, we're also integrated via Smart on FHIR into the patient portal. So this is the patient portal. At the bottom left, you see Diabetes Plus Me. When the patient clicks that first time, they're asked if they authorize access. And once they do, then they're launched into our system within their patient portal. From that point forward, whenever they launch the application via native app, via web service, we make those FHIR calls and update their information so that patients also have access to labs and medications, as well as to those notes that the clinician wrote about them in our system. A little bit about sort of where we are in outcomes. So we have done a randomized controlled clinical study of this with the Pioneer ACO in California, and have been able to show greater impact on reducing hemoglobin A1C, reduction in total cost of care of patients, $300 per patient per month, as well as reduction in cost of delivering that care. And I think that's a big point that's often overlooked. If we are going to manage populations at scale, we have to find efficiencies in care delivery. So in this case, they were able to manage 3 times as many patients with the same number of providers. We're now commercially deployed in several other healthcare systems. And I don't know why David at HL7 is in the middle of my slide, but this is what sort of our pathway looks like. So we're in Cerner's marketplace, we're in Athena's marketplace, and we'll be moving into additional providers as their FHIR implementations grow. And then we're launching additional modules, so congestive heart failure is the next one that we're doing, and we're excited to move those into FHIR as well. So thank you very much.